Welcome everybody. Now we will start this afternoon session. It will be MDT approach to some common clinical scenarios. The first case, it will be female presenting with a palpable mass diagnosed on imaging as a Biret's 3 lesion.
Good afternoon. Before we start, BI-RADS 3 is an indeterminate category in the BI-RADS system. Finding placed in this category is considered probably benign with a risk of malignancy of more than 0% and less than or equal to 2%. Mammographic findings that fall under the BI-RADS 3 category include grouped round calcifications, circumscribed round or oval masses without calcifications, and a focal asymmetry without calcifications or architectural distortion. The following sonographic findings may be characterized as BI-RADS 3, a complicated cyst with uniform low-level echoes, microlobulated or oval mass composed of clustered microcysts, a hypoechoic circumscribed oval parallel mass without posterior features or with minimal posterior enhancement, or a hyperechoic mass with central hypoechoic to anechoic components and surrounding edema that's consistent with but not diagnostic of fat necrosis. Our first case is a 30-year-old who came to Bahia complaining of a left breast mass that's increasing in size. Clinically, this breast mass was felt. She had mammography and ultrasound done outside Bahia 10 months prior, and it showed an upper-outer quadrant dense mass. The ultrasound revealed a hypoechoic lobulated mass that measured around 30 or 3 times 2 centimeters and showed some vascularity on application of color Doppler. The ultrasound in Bahia showed a hypoechoic solid mass lesion with an irregular border and internal cystic changes extending from 2 to 4 o'clock, measuring around 7 times 5 centimeters with an increase in the vascularity. So this mass essentially has almost doubled in size. The mass was categorized as a BI-RADS 4 and a biopsy was recommended.
Local biopsy shows benign fibroid tumor.
A quick note on what a fibroadenoma is. They are the most common solid breast masses in women of all ages. Their peak incidence is between 25 and 40, and this incidence should decrease after 40 years. They can be categorized as a simple fibroadenoma, which is typically commonly seen with typical radiological features, a giant fibroadenoma, which is a fibroadenoma that's more than 5 centimeters in size, a phylloid tumor, which is typically a large, fast-growing mass that forms from the periductal stroma of the breast. It's sometimes difficult to differentiate from a fibroadenoma from a phylloid tumor on imaging. The last category, a complex fibroadenoma, is a term that is used when there is associated cystic changes that's more than 3 millimeters, epithelial calcifications, sclerosing adenosis, or papillary apocrine metaplasia. These findings can be seen on mammography or on imaging, as an irregular border, cystic changes with apocrine metaplasia, or an increase in size when the lesion appears hypervascular. And the microcalcifications can be seen as echogenic foci on ultrasound. Our second case is a 28-year-old. She came complaining of bilateral lumpy breasts, and clinically these lumps were felt as masses bilaterally. In November 2019, an ultrasound was performed in Bahia, and the masses were seen as bilateral, probably benign solid masses, likely fibroadenomata, and she was given a BI-RADS 3 lesion. The patient came for follow-up 6 months after, and the previously reported left breast upper outer quadrant solid mass is now seen as 2 suspicious hypoechoic solid mass lesions with increased in size and non-circumscribed margins measuring 4 times 2 and 3 times 2 centimeters. There was internal peripheral vascularity on application of color Doppler, and the patient was given a BI-RADS 4 category and biopsy was recommended. MRI was also performed, and it showed masses with irregular outlines displaying low T1 and low T2 weighted images with restricted diffusion. They showed intense heterogeneous enhancement. The largest was seen at 1 o'clock with central areas of cystic degeneration measuring about 5 times 3 centimeters, 3 millimeters away from the skin. The deepest one is located at 12 o'clock and is resting on the pectoralis muscle without definite infiltration. PEM was also performed, and it was a positive study for metabolically active FDG-avid multicentric left breast malignant masses, BIRAT6. The PEM was performed after the biopsy, and thus the patient was categorized as a BIRAT6.
True-cut biopsy shows invasive duct carcinoma grade 2 with intermediate grade DCIS metastatic to the lymph node.
Case number 3 is a 47-year-old patient. She came complaining of mastalgia and had a right breast lump by clinical examination. In 2019, a mammography was performed and it showed a heterogeneously dense breast parenchyma and a grouped cluster of lower calcifications that was seen in the right lower inner quadrant. On ultrasound, there was a right 9 o'clock clear cyst measuring about 1 times 1 centimeters, and this was classified as a BIRAT2 lesion. And the same breast at 3 o'clock, there was a lobulated, well-defined hypoechoic lesion measuring about 1 times 0.6 centimeters, and this was given a BIRAT3. In 2021, she came again for her follow-up. We had the stationary mammographic appearance. By ultrasound, however, the simple cyst now showed the turbid content within, and was thus given a BIRAT3.
High needle aspiration cytology shows few papillary clusters.
And wire localization was performed for that cyst in September 2021. The patient had a stationary appearance, mammographic and ultrasound in 2022. She came again in 2023, stationary mammographic appearance, including that of the clusters of cysts that were previously seen in 2019, with the artificial intelligence giving a reading of 69% in the last study. By ultrasound, there were retroareolar and paraareolar dilated ducts with multiple intraductal echogenic contents, some of them showing internal vascularity. The largest was seen at around 1 o'clock away from the nipple and measured about 14 times 6 millimeters. The picture was suggestive of papillomatosis, and the patient was given a BIRAT3 category.
Core biopsy shows nodular sclerosing adenosis. Core biopsy shows nodular sclerosing adenosis, and then wire-guided wide local excision shows papilloma with low-grade DCIS.
The take-home message for this presentation is any lesion that's given a BIRAT3, and after exhausting all the clinical and diagnostic information that we have, whether the patient will perform mammography, ultrasound, or if MRI is indicated if there's any suspicion, and the end result is a BIRAT3 lesion, then this lesion should be followed up at an interval of 6, 12, and 24 months. If there's a decrease or a stability or actually a resolution of the lesion, that this could be downgraded to a BIRAT2 for annual screening. However, an increase in size or any suspicious finding that we encounter in the follow-up, especially if there is an irregular margin, an increase in size, an increased vascularity, a biopsy should be performed, keeping in mind that there are some benign mimickers, including medullary, mucinous carcinomas, fibroadenoma that may have atypical features, so this should be resolved by a biopsy. If the lesion is initially suspicious, and any of the previous findings are found on the initial imaging, a BIRAT3 should not be given, and biopsy should then be performed. Thank you.
Okay, thank you for this nice presentation. Again, BIRAT3 is usually the problem. For second case, I want to ask about the role of PET-CT in a patient having a BIRAT3 lump in her breast. It is PET-CT has an actual role, or because yes, okay.
The PEM was performed after the biopsy was done, and the patient was actually.
What is the role of this PEM, please?
To exclude if there's other multicentricity. The patient has a heterogeneous breast, for example, and the MRI showed, because the MRI usually has a low specificity. So if we are suspicious of any findings, and the patient will be undergoing surgery, the PEM can actually solve any equivocal lesions
So you are seeking for another lesions,
To exclude that
for
there's
the
something else, and
multiplicity.
these are the only lesions that are seen by MRI, to exclude that there's another lesion on the other side, especially if the patient is young and there's fear of DCIS or any other lesion that could be found in the other breast that could alter the management.
Okay, if I don't have it, it's not available for me, can I replace it by MRI or contrast enhance it?
Yes, if there's something seen on MRI that cannot be biopsied, then this lesion could be put on follow-up in the other breast, for example, and this lesion would not be involved in the management of the example. There's a surgery planned. Then the other lesion, the other breast, can be put on follow-up by MRI since we don't have.
The technique, of course, is costly and not available everywhere. So the technique is costly and not available everywhere.
Just enhanced mammography. But
Okay.
sometimes we have
Okay.
a lesion that's seen on MRI, but not seen on conscious mammography. It's a focus that's enhancing.
Yes.
So this is the problem with MRI.
Yes.
If we have any suspicion, we should keep it on a follow-up MRI examination to make sure that it doesn't evolve into something else. If they're the same in conscious mammography, then conscious mammography, of course, is a simpler, more available, less costly technique.
Thank you.
I want to say that we will begin with MRI first.
Yes.
We will begin with MRI. If we cannot do MRI, we can do contrast mammography. If we cannot do the same, we will resort to PAM. So it's the last resolution, the
That's
PAM.
not available.
If available,
Yeah.
if available. It's but in Bahia it's available, so that's why you did it, yeah. But first you will try to do MRI first, and then contrast, and then if there is any problem, there is renal impairment or anything, we will shift to PAM. Okay, thank you. Thank you, Sherihan.
I really like the way you are introducing your concepts. I think the bottom line here, from a clinical perspective, you need to have a learning MDT. It shouldn't be a one-person decision upon BI-RADS 3.
Of course, and it is, we should have had a surgeon with us.
Wonderful. This is for all others who are not working in Bahia. I think the second take-home message is, if you have a young lady, 30 years, with a 7-centimeter lump in 2023, this is nonsense. We need, it's our responsibility, to give much time to our patients, to tell their families that we need to have what it seems to be early detection or screening. This is very important, not only by RAD 3. I'm so thankful.
Thank you, Dr. Sharihan, for the presentation. I want to attract you to the medical oncology field. Now, what should we do for this patient with very small, low-grade DCIS? Went to a conservative or wide local excision. What is the next step? Should we give the hormonal treatment? The benefit would overweight the harms of the hormonal treatment, or should be put only under follow-up? Or go to the small dose tamoxifen as the last trials telling us it gives the same effect. I need your comment.
It's a very tricky question, and this is because of the advanced digital whatever. Don't forget about the long-term outcome you are looking for. DCIS, irrespective to size, I think my professors may correct me if I am wrong, the hormone treatment here is not truly a treatment. It's more or less for the contralateral prevention, and this is a very old studies. Yes, I think we need to think more into the patient. Does she has a family history? She is a very risk patient for developing future, whatever. So it's a matter of judgment. Till today, medicine means trained physician, not yet an AI, and I think it will not be. If she is my case, and she is young and have a small DCIS, I'll not make her life difficult with estrogen deprivation. I don't know.
I think the role of hormonal therapy is very important because it acts mainly as a chemo prevention and as not only as a treatment to decrease the risk of recurrence, but also to decrease the contralateral affection as a chemo prevention. The tricky question may be regarding the role of radiotherapy in such young patient. This is a problem. Can we give radiotherapy for a patient with 28 years or 30 years? Because I have some patients with DSIS with positive family history with 17 years. whether to give or not to give radiotherapy, whether to give or even the tamoxifen itself may be contraindicated below age of 18 because we don't have data. But actually, hormonal therapy is very important even in low grade. Yes. Yes, yes.
Because there is no data to tell you about the impact of certain sectors.
The value of hormone receptor regarding the risk of local recurrence of DCIS in the same breast. But if you are talking about the chemoprevention for the contralateral or another Denevu primary, yes, it acts as a chemoprevention, especially if the patient has strong family history.
We'll shift to the second. Thank you, Sherihan. Thank you, doctor. The next one is the teamwork made of about female presenting with inflammatory signs of the breast. It's another dilemma. BIRAS 3 is the first dilemma, and then the inflammatory breast is the second dilemma. The teamwork is presented from Dr. Ahmed Al-Mu'azz, Dr. Nermeen Mustafa, Dr. Salwa Yahya, and Dr. Nesma Salah.
Good afternoon, dear professor and colleague. Our presentation today about female presenting with inflammatory sign of the breast, teamwork including Dr. Ahmed Abdelmuiz, Dr. Salwa Yahya, Dr. Nesma Salah, and I am Dr. Nermeen Mustafa, Assistant Lecturer of Medical Oncology, NCI, Cairo University, and Medical Oncology Specialist at Bahia Hospital. Let's start our presentation with the first question that should be taken in our mind when patient presented with inflammatory sign of the breast. What is the differential diagnosis of inflammatory sign of the breast? The differential diagnosis may be infectious mastitis, non-infectious mastitis, or malignant mastitis. Infectious mastitis may be simple mastitis, lactation mastitis, complicated mastitis with abscess formation. And non-infectious mastitis may be granulomatous mastitis, diabetic mastitis, and periductal mastitis. Malignant mastitis may be inflammatory breast cancer or malignant breast abscess. How to diagnose the inflammatory sign of the breast? The algorithm for diagnosis including a history, physical examination, investigation by ultrasound or mammogram, plus minus biopsy. As we show in this slide, if patient presented with the inflammatory sign of the breast, the first investigation modality is ultrasound and mammogram, and if we found cancer sign, tissue biopsy is mandatory, plus minus breast MRI in selected cases. If no cancer sign can be detected by ultrasound or mammogram and there is a collection, tissue biopsy and microbiological analysis, then medical treatment according to the result of the biopsy. If no cancer sign and no collection, we should start by medical treatment and assess the patient clinically. If improved, for follow-up by ultrasound every 3 months. If no improvement, consider tissue biopsy and microbiological analysis, and then treatment according to the results. Today, we will discuss 3 case scenarios about inflammatory sign of the breast. The first, infectious mastitis, lactation mastitis. The second, non-infectious mastitis, granulomatous mastitis. And the third, malignant mastitis, inflammatory breast cancer. We will start the first case with Dr. Ahmed.
47 years old female patient, premenopausal, performance test 1, lactating mother, while 47 years, medical history and family history negative. The condition started by swelling in the left breast and pain in the right breast while she breastfed her son at September 2021. Clinical examination showing mass 4 cm in the left breast and mild redness in the right breast. Bilateral sonography showed left breast and right breast dense owing to lactation. MRI breast. Right breast diffuse non-mass enhancement, likely diffuse inflammatory change, and left retroareolar regional non-mass enhancement with low T2 signal, reduce the breast size. The question now, what is the next step for this patient? Biopsy was taken from the left breast and showed invasive lobular carcinoma, grade 1, ER positive, BR positive, HER2 negative. So the MD decision at that point was supportive treatment with antibiotics for right breast inflammatory changes, then follow-up breast sonography, and neoadjuvant chemotherapy for the left breast lesion, followed by left MRI. Patient started antibiotics for 7 days, and clinically right breast pain improved. No inflammatory change detected clinically after treatment. Then started treatment for the left breast cancer with neoadjuvant chemotherapy, AC followed by Taxol. This is a bilateral sonography after neoadjuvant, showed right breast tissue, no inflammatory change. Left MRM was done and showed mixed invasive duct and invasive lobular, grade 2, lymph node 11/14, residual cancer burden 40%, grade 3, pathological T2 in 3. Patients needs adjuvant radiotherapy and hormonal treatment, tamoxifen and Zoladex.
Case 2, 38 years old female patient presented with right breast hard palpable lump. Negative medical and family history, clinical examination showing right upper outer quadrant mass, 4 by 4 centimeter with ipsilateral deviated nipple. So bilateral sonomammogram was done showing right breast upper outer quadrant focal asymmetry corresponding on ultrasound to highly suspicious altered parenchyma given by RADS4 with ipsilateral single indeterminate axillary lymph node. Biopsy was taken from the right breast lesion, showed inflammatory cells with microabscesses. No malignant cells were detected. So what's the next step? Our MDT decision was contrast-enhanced MR and re-biopsy from the most suspicious area detected on the MR. Contrast-enhanced MR showed right breast upper outer quadrant, segmental area of heterogeneous non-mass enhancement showing variable degrees of diffusion restriction. So the re-biopsy was done from the most suspicious area detected on MR, also revealed inflammatory cells with formation of microabscesses, no malignancy. Patient was referred again to the MDT. They requested BEM study for further evaluation due to discordance between radiology and pathology results. BEM study showed right upper outer quadrant regional area of avid FDG uptake with central photopenic areas. After that, after 2 days after PEM study, the patient presented to the hospital with severe pain, tenderness, redness, and edema of the right breast. Ultrasound was done, showed newly developed multiple intercommunicating pockets of collections with inflammatory breast signs, in keeping with granulomatosis mastitis. So limited complementary MR on T2 and STEER images showing multiple intercommunicating pockets with inflammatory breast changes. The patient was started treatment with steroid daily and the symptoms improved after 3 weeks. The patient kept under follow-up with low-dose steroid.
The third case scenario is 64 years old female patient, postmenopausal, ECOG performance status 2, diabetic, hypertensive with history of bronchial asthma and negative family history. The condition started in November 2022 by mass with redness, hotness, and edema at right breast. Clinical examination showing right breast occupying whole breast, right breast mass occupying whole breast with redness and good orange and axilla can't be assessed due to lymphedema. And also there is left breast thickening with good orange and redness. Bilateral sonomammography done at November 2022 and showing right breast diffuse edema pattern with nipple retraction and corresponding with ultrasound retroareolar suspicious area of altered echogenicity by RAD4 with a few pathological right axillary lymph node as well as mild left breast skin thickening. Contrast MEM was done at December 2022 and showed right breast retroareolar regional area of pathologically non-mass enhancement, left breast upper outer quadrant intermediate fat enhancing nodule by RAD3 and left axillary lymph node intermediate nature for fine needle aspiration. Biopsy was taken from the right breast and showed invasive ductal carcinoma grade 3 with pleomorphic lobular differentiation. And biopsy was taken from the left axillary lymph node showing metastatic adenocarcinoma of breast origin. ER and BR and HER2 on both sides are negative. The first question was, what about the metastatic workup? CT was done in December 2022 and showing right pleural effusion mild with bilateral subcentimetric pulmonary nodule for follow-up and dorsal vertebrae 6 small lytic lesion. The second question was if this patient had bilaterally inflammatory breast cancer only or metastatic disease or need further investigation. And at that point, MDT decision was to do PET-CT to exclude or confirm metastatic disease. PET-CT done at December 2022 and showed only bilateral breast lesion with bilateral axillary lymph node with no metastatic deposits. So this patient diagnosed as bilateral triple negative inflammatory breast cancer for neoadjuvant chemotherapies and bilateral MRM. Let's overview the NCCN guidelines for inflammatory breast cancer. The inflammatory breast cancer is a rare aggressive form of the breast cancer, and it's a clinical diagnosis mainly that require erythema and dermal edema of the third or more of the skin of breast. And it's classified mainly as a stage 3B or stage 3C or stage 4 breast cancer depending on the degree of nodal involvement or whether distant mets are present or not. This slide shows the workup for inflammatory breast cancer according to NCCN guidelines, which including history, physical examination, complete labs, pathological review with biological profile, fertility counseling in premenopausal, and genetic counseling in high-risk patients, and imaging including bilateral sonomammography, CT chest, abdomen, pelvis, and bone scan, PET-CT, and breast MRI in selected cases. And as we show in this slide, this is a pre-operative chemotherapy regimen for HER2-negative inflammatory breast cancer according to NCCN guidelines that include multiple regimens with specific consideration for triple-negative breast cancer that didn't achieve complete response after neoadjuvant chemotherapy and need adjuvant capecitabine. NCCN guidelines following a pre-operative treatment for inflammatory breast cancer, including if patient achieve complete response, if patient achieve response to neoadjuvant chemotherapy, the next step is total mastectomy plus axillary lymph node dissection plus or minus delayed breast reconstruction, then adjuvant treatment according to biological profile of each patient. If no response, we will consider second-line chemotherapy, then treatment according to the response to second line. To summarize the data of our patient, 64 years old, diabetic, hypertensive, ECOG2, had bilateral inflammatory breast cancer, triple negative, blamed for neoadjuvant chemotherapy, then bilateral MRM. Patient presented in medical oncology department with mild dyspnea and tachypnea, which make us suspect an emergency condition, including pulmonary embolism. And investigation was done, including CT pulmonary angio and confirmed diagnosis of pulmonary embolism, and patient started oral anticoagulant. The question was, what should we do with this patient? Starting chemotherapy now or waiting till improvement of dyspnea and tachypnea and general condition? We started neoadjuvant chemotherapy with less toxic drug, paclitaxel plus carboplatin weekly till improvement of general condition. And after 12 weeks of treatment, clinically the patient showed mild response in the form of improved inflammatory change of the breast, but size of the right breast and axillary lymph node was the same. So we do CT to assess the response to treatment, and CT done showing mild regression of bilateral axillary lymph node plus newly developed diffuse small sclerotic osseous lesion likely mets. Now, is this patient considered having metastatic disease and will receive palliative treatment or need further investigation with bone scan or PET-CT? MDT decision at that point to repeat PET-CT to be compared with the first PET-CT done and to confirm or exclude bone mets. And PET-CT done and confirmed non-metastatic disease with stationary disease of the right breast and axillary lesion. And patient then continued full course of neoadjuvant chemotherapy with anthracycline-based regimen and showed marked response clinically to anthracycline. Then underwent bilateral MRM at May 2023, and pathology showed right MRM invasive ductal carcinoma grade 3 viability 5% with residual cancer burden 1, and left MRM invasive ductal carcinoma grade 3 viability 10% with residual cancer burden 2. Now patient on adjuvant chemotherapy with capecitabine and waiting for post-operative radiotherapy. Take-home message: not all patients presented to us with inflammatory sign of the breast had a malignant disease. We should exclude benign condition before proceeding for investigation and treatment. history and the initial physical examination help us to go in a proper track for proper diagnosis and treatment of the patient. Ultrasound plus minus mammogram is the first investigation modality used to assess the inflammatory breast. Tissue biopsy should be considered in benign condition who didn't respond to medical treatment. And MRI should be considered in some patients where bilateral sonography not conclusive of diagnosis. If we confirm a malignant inflammatory breast cancer, we should proceed for treatment with proper regimen of chemotherapy according to the biological profile of each patient, followed by operations and adjuvant treatment. And finally, thank you so much for attention.
Thank you very much for this excellent presentation. I want to ask why this patient is not given the option of Keytruda or immunotherapy.
Because it's not available at Bahia.
Another point I want to stress on it, that inflammatory breast cancer is a pathological diagnosis, not merely a clinical diagnosis. Okay, we have to take biopsy to prove that it is malignant. Not all inflammation as you presented in the first and second case. So we have to take biopsy, and we cannot diagnose inflammatory breast cancer just clinically. Okay.
Thank you for this presentation about the three cases. My comment about the first case. And for the oncologist, of course, what's the value of addition of LHRH to Nolvadex for such patients with luminal type breast cancer 47 years old? Either you can give her adjuvant as AI, one of the AI, because of course she has high risk, 11 lymph nodes positive, YB after new adjuvant first, or if you already started tamoxifen, still she has a role to add LHRS after receiving 8 cycles of neoadjuvant chemotherapy. Most probably she's now right, is postmenopause. So for me, why to add LHRH for such patient with 74 years old?
Because she's young.
She's 47. Yes, 47, I know. 47, after receiving 8 cycles of neoadjuvant, most probably she will not regain menses. But anyway, by evidence, the value of ovarian suppression is usually manifested below the age of 40, if she's 47. So I didn't think. If so, you can start with AI. Of course, AI is much better for her and has associated with better progression-free survival because she is high risk. YB T2N3, right?
She's 47, but she was pregnant and lactating.
Okay,
I think that's
yes.
the cause. She was on the Zadex because of that.
Most of the data or trials proves that the value of addition of ovarian suppression usually about 35 or 40 years, but I know the patient is still premenopausal at time of treatment.
Exactly. So, if we looked at the literature, we'll find that the gozerline has improved the overall response rate within high-risk individuals.
Yes.
And being N3 is considered high-risk. The issue is with neoadjuvant chemotherapy, she will go into menopausal status. Yet, we see a lot of patients that they do have their hormones back up again. So, if she's a high-risk, and I'm waiting for, because to tell you the truth, we don't follow up with the E2 levels properly and FSH and LH. So, to take the safer side, we should give the gozerline, I believe, here in this patient because she is a high risk, super high risk, not high risk.
Is a risk, I agree with you, I guess. But for me, I better to start with AI for her. If I use LHRH, I induce ovarian suppression, of course.
Okay, thank you. With ovarian suppression, yes, I agree with AI, definitely, 100%.
Magdi, to be clear, because we have here in senior staff and also junior staff, to keep with the guidelines with data of adjuvant treatment for those patients, either premenopausal or postmenopausal, either receiving tamoxifen plus LHRH or AI plus LHRH. There is a rule of abemaciclib in adjuvant setting in this case, keeping the monarchy trial. I know that it's not available, but should not availability to talk beyond the level of practice. Nowadays, any patients for nodal disease more than 4 or equal than 4 or more, or N1 disease with grade 3 tumor or tumor more than 5 centimeters, she should receive 2 cycles or 2 years of abemaciclib plus tamoxifen plus HRH. My question for the third case, you started a chemotherapy with symptomatized patient with pulmonary embolism, and she started oral anticoagulants. It's not a common
Patient
practice
start
for those cases.
anticoagulant for 4 days, then start chemotherapy.
Yes,
Not at the same time.
oral, not IV. Because the classic wise to treat symptomatic patients by VTE recommendations for benevolent patients for coronary scoring system to start with 10 days at least indoxaprine, 1 milligram per kg twice daily. Then when a patient be symptomatic, not asymptomatic, you can go for active treatment because it's very risky to start with active pulmonary embolism to start with chemotherapy.
The last comment, excuse me, the value of addition of platinum compounds in the neoadjuvant for triple negative patients. This matter have been markedly exhausted in search. Until now, there is no evidence of addition of platinum in the neoadjuvant except in patients with BRCA mutation. I know you don't have the result. You have the result of BRCA.
So what if third case, we did BRCA, she's positive, and then we are allowed to give, so she's positive BRCA, and you have the opportunity to use pembrolizumab.
Okay, this is a conflict have been
Yes,
listed
I know.
many times before. If the immune is available and the patient with BRCA, can we use both or not? Of course, we don't have data, but for me, I will start with immune, and if I have the chance to continue with later on with the, of course, PARP inhibitors.
Okay, so because we do have data, actually, they have been asking the data, the Keynote 522, the PI himself said, if the patient entered in pathological CR, what is the benefit of continuing the pembrolizumab?
Yes, keeping with Keynote 522.
We have to continue.
We have to continue.
Yes.
Either the patient didn't achieve PCR, have a more benefit from addition of Bembro, not
Yes.
like the patient achieving PCR.
Yes, definitely.
But the benefit is there.
Definitely.
The question may be modified to how to give capecitabine plus Bembro or Olapri plus Bembro,
Bembro.
but you have no trials for this design.
No.
You have attacked to the design of Keynote 522. Concerning for your first question to Mohammed Magdi about either to give anti-BRCA or anti-PD-L1 in the M setting, M1 setting, or both. All data giving Bembro or Atezo in the second line treatment are dismal with a response rate of 5%. That's why the best chance to give Bembro is to the first chance in the M1 setting.
Yes.
If you are giving Bembro or Atezo in second on second, you have a lot of data of Keynote 073. There is dismal data of second line Bembro. So the best chance to give immunotherapy is the first chance.
Keynote 355.
Yes.
This is the best outcome.
The best Keynote 555 and patient 031
Yes.
or 030, all of them giving the Bembro or Atezo in the first line.
But we all know that Roche already
because,
withdrew the atezolizumab because it, in combination with chemo, it did not differ much, and only with the
We have two
nab-paclitaxel.
trials.
Only with the
We have two
nab-paclitaxel.
trials, Keynote
030,
031
yes.
and 030.
Yes.
Both are failed primarily for the Taxol,
Yes.
Taxol, and then Paclitaxel didn't achieve the FDA approval, but still approved till date.
Yes, yes.
So the Keynote 355 is there, but for a first line.
Yes.
If you are give Olapari, you can give it at second line or third line.
Definitely.
Keeping good
Definitely, yes. Right.
Getting back to basics, the basic idea here is when to escalate treatment and when to choose to de-escalate treatment. I have only one comment as a clinician at the end of the day. Invasive lobular carcinoma is a very tricky subtype. It has no ECadherin in the cell, so it is spreading. PET-CT has a very large false negative results. So when you think in a PET-CT, زي ما كان الدكتور بيقول لنا من شوية, it's a two imaging in one machine. you should look to the CT component. It should be a diagnostic quality CT with a bone window part لو انت قلقانه ان عندك bone metastatic جديد. This is the only clinical perspective comment.
We were not suspecting bony mets because of the alkaline phosphatase was not high and it was sclerotic, not lytic.
Believe me, if she has a bilateral aggressive disease, she is potentially metastatic.
Yes. Yes.
You are trying to give her the best chance to treat her from a curative intent, but it is a huge disease at presentation.
Yes. Also, the MRI has a role.
Thank you.
We do PET mammography in Bahia Hospital, and even with PET mammography, which is more specific than PET CT, many lobular carcinomas do not show ال POV وكده بتبقى واضحة جدا زي البناين.
Next talk will be management of contralateral positive axillary lymph nodes, a clinical dilemma, by Dr. Mahmoud Hassan, Dr. Nisma Mohammed, Dr. Reham Anwar, and Dr. Yasmin Yasser.
Good afternoon. It's a pleasure to present the topic today, management of contralateral positive axillary lymph node. I'm Dr. Mahmoud Hassan, lecturer surgical oncology at National Cancer Institute, consultant Bahia, with Dr. Nisma Mohammed, consultant pathology, Dr. Reham Anwar, consultant of radiology, and Dr. Yasmin Yasser, assistant lecturer, medical oncology at the National Cancer Institute. The management of contralateral positive axillary lymph node is a clinical dilemma. Whether we treat this patient with curative intent or palliative intent. The problem is that contralateral axillary lymph node metastases are an uncommon finding in breast cancer. The rarity of the contralateral axillary lymph node has been a controversial topic, and the uncertain laterality of the cancer responsible for this metastasis complicates the overall disease staging and is a management dilemma for the clinician. And there remain controversy over whether contralateral axillary lymph node should be considered a distant metastasis or a loco-regional spread. The controversy in this topic about the stage, what the mode of spread of malignancy to the opposite axilla, either hematogenous or lymphatic. Contralateral axillary metastasis is a part of a systemic disease or it is a presentation of a localized disease in the contralateral breast. Can we consider it's a loco-regional disease in absence of other distant metastases? And what is the intent of treatment of such patient, curative or palliative intent? And if we manage with a curative intent, will they have a better survival than patient with other systemic metastases? Contralateral axillary lymph node is an M1 disease, not a regional lymph node from the same breast. According to the NCCN guidelines, the contralateral axillary lymph node as a stage 4 disease because contralateral axillary lymph nodes are not considered the original extent of the disease but a distant metastasis. Recently, many studies have found that the disease-free survival and overall survival of the contralateral axillary metastasis patient were similar to those of M3, M0 patient and significantly better than those of patient with other distant metastases. Even if contralateral axillary metastasis is not regarded as a distant metastasis, the lymph node stage would then be N3, which is still advanced and poor prognosis. The mode of spread, although the precise mechanism of contralateral axillary metastasis is not known, but many theories, it may be a metastasis from a contralateral breast cancer or metastasis from an occult primary in the ipsilateral breast, or metastasis from other organ, extramammary site. And we can rule out the second and third cause using by the help of imaging modality. Contralateral axillary metastasis and the pathology, there is an association of contralateral axillary metastasis with aggressive histopathological feature in patients who have breast cancer, such as higher tumor grades, lymphovascular system invasion, larger primary tumor, ER negative patient, and HER2 overexpressed patient. In most cases, contralateral axillary metastasis and their primary tumor have similar histopathological feature? And what if the contralateral axillary lymph node is different pathology? We should go for investigation to detect either the occult primary in the contralateral breast or to detect the metastasis from the extramammary side as an MRI, routine MRI, core biopsy from the contralateral axillary and immunohistochemistry on the specimen, and PET-CT. Contralateral axillary metastasis may be synchronous at the same time of the primary breast cancer or metachronous after the treatment of breast cancer in the contralateral breast, and most cases are metachronous. ممكن حد يساعدنا بس في Okay, sure. What's the management? The traditional management differ in the synchronous or metachronous. We can manage this case as an occult primary or palliate this case, or we treat in a curative intent. And when we treat in curative intent, what's the role of surgery? We do mastectomy or just axial lymph node dissection and the radiation therapy, and what's the role of neoadjuvant treatment and the prognosis of these cases. Till now, there is no clear guideline for management of patient with a contralateral axillary metastasis due to the rarity of the condition, and there is no standard treatment or guideline for contralateral axillary metastasis. And patient need to be individualized in the treatment. According to the guidelines, contralateral axillary metastasis normally treated as a systemic disease. All cases of contralateral axillary metastasis have been regarded as distant metastasis and treated with systemic therapy as either chemotherapy or hormonal treatment, and the effect of axillary lymph node resection is insufficient and mastectomy is not recommended. However, some case reports and limited publications publish that there is better prognosis in the case either asynchronous contralateral axillary metastasis when treated in a curative intent. Also, the metachronous contralateral axillary metastasis, some studies have reported the patient who developed contralateral axillary metastasis without other metastases should be categorized as a leukoregional disease, and the treatment of patient with isolated contralateral axilla with axillary lymph node dissection followed by systemic therapy and radiation therapy. The role of surgery, unfortunately, due to the rarity of the condition, and there is a poor evidence on the role of surgery for such cases. But contralateral mastectomy is not recommended for the low incidence of contralateral occult breast cancer, except for some special situation as genetic breast cancer and contralateral axillary metastasis with a different pathological and immunohistochemical feature from the primary tumor. But still, the prognosis of the contralateral axillary metastasis patient could be improved by axillary lymph node dissection and radiation therapy. We'll present an example of a case of synchronous contralateral axillary metastasis and a metachronous contralateral axillary metastasis. The first case, a 40-year-old female premenopausal woman, negative family history, presented to us with a left locally advanced disease, T4P, with omitted left axillary lymph node. Investigation were done, revision of the sonomammography done outside the center, and CT for staging, and true cut biopsy from the left breast mass.
Contrast enhanced mammography showed left breast multicentric pathologically proven intensely enhancing malignant masses with ipsilateral axillary and supraclavicular pathological lymph nodes. Bilateral moderate background parenchymal enhancement was seen. Right breast upper inner quadrant showing faint heterogeneous enhanced lesion with which was corresponding by ultrasound to circumscribed hypoechoic lesion, so categorized as probably benign lesion by RADS3. Right axilla showed level 1 indeterminate lymph node with focal cortical thickening measuring 6 millimeters. CT chest, abdomen, and pelvis study was done for staging, which showed the left breast malignant process with ipsilateral, axillary, internal mammary, and supraclavicular pathological lymph nodes. Right axillary indeterminate lymph node was seen, with no distant metastasis to the rest of the organs. Ultrasound guided core biopsy was taken from the right axillary indeterminate lymph node.
Left breast shows invasive duct carcinoma grade 2. Right axillary lymph node show metastatic adenocarcinoma, ER strong positive, PR moderately positive, and HER2 negative.
MR study of the breast was done to assess the contralateral breast, which showed upper inner quadrant intensely enhancing homogeneous lesion with restricted diffusion and type 2 or plateau curve. So the lesion categorized as suspicious or by red 4. MRI can detect cancer in the contralateral breast that is masked by mammography and clinical examination at the time of the initial breast cancer diagnosis. A negative contralateral breast MRI has a very high and reliable negative predictive value, therefore is helpful in managing counseling patients during the period of initial diagnosis and early treatment. Ultrasound guided core biopsy was taken from the right axillary, from the right breast upper inner quadrant suspicious lesion.
Right breast shows nodular sclerosing adenosis with fibroadenoptoid shapes.
Okay, there is a case discussed at the MDT, and the decision was to start neoadjuvant systemic treatment followed by left modified radical mastectomy and right axillary clearance with localization and excision of the sclerosing adenosis area. Patient received neoadjuvant chemotherapy, AC 4 cycle followed by Taxol, followed by surgery. After wire localization lil upper inner quadrant lesion. Here the post-operative pathology.
Left breast MRM show multifocal invasive duct carcinoma grade 2, T1 N1, residual cancer burden 2. Resection margins are free. Axillary lymph node show positive metastasis 1/18 with extracapsular infiltration and focal therapy effect. Right breast excision biopsy shows nodular sclerosing adenosis with fibroadenomatoid changes. Right axillary lymph node show positive metastatic duct carcinoma 2/10 with focal capsular invasion.
And patient received the adjuvant radiotherapy and the hormonal treatment and follow up till now since 2 years. Okay, the second case.
Now we'll discuss the second case. We are having a 62-year-old postmenopausal female, which was diagnosed as left breast cancer since 2018. Initially, she presented with locally advanced left breast cancer and ipsilateral axillary mated lymph nodes. She underwent staging that showed no metastasis, and the axillary lymph node biopsy showed metastatic invasive duct carcinoma of breast origin. ER and PR and HER2 were negative. She was planned by MDT for neoadjuvant chemotherapy. She received EC Taxol, EC for 4 cycles, followed by Taxol for 12 weeks, after which she underwent left MRM that revealed complete pathological response, and then she received post-operative radiotherapy and kept under follow-up. She was kept under follow-up every 3 to 4 months with clinical examination and annual mammograms. 2 years later, in May 2022, she developed a contralateral axillary lymph node. Right solo mammography was done, which showed the newly developed right axillary level 1 pathological lymph node with no right breast solid or cystic lesions were detected. Then CT, chest, abdomen, and pelvis study for stage was done, which showed the newly developed right axillary level 1 pathological lymph nodes with no distant metastasis. Ultrasound-guided core biopsy was taken from the right axillary pathological lymph node. Core needle biopsy is more effective than fine needle aspiration cytology in evaluating the axillary lymph nodes in the breast cancer. Ultrasound-guided core needle biopsy for axillary lymph nodes can be useful in examining lymph nodes with metastasis and recurrence because the tissue biopsy can provide information on the diagnosis of the lesion and its pathologic features.
Right axillary lymph node shows metastatic adenocarcinoma. Positive for GATA3 with PR, ER weak positive, PR negative, and HER2 negative.
Dynamic MRI of the breast was done, which showed no right breast enhancing lesions. After the biopsy was taken, that showed that the axillary lymph node was triple negative as the initial breast cancer, left breast cancer, and after the staging was negative, she was planned for right axillary clearance that was done in June 2022 and was pathologically N1. 3 out of 19 lymph nodes was positive. She then was followed with adjuvant post-operative radiotherapy and Xeloda for 8 cycles. To conclude, contralateral axillary involvement in a female with a current diagnosis or a history of breast cancer represent a current diagnostic and treatment dilemma. Since this condition is infrequent, traditional wisdom advised that we could treat this case as a stage 4. However, many studies and many papers and many data advise that contralateral axillary metastasis outcome, if was treated as with curative intent, will improve the overall survival. We should advise or try to assess the guidelines for treating CAM as a regional disease, not a metastatic disease, as what happened with supraclavicular lymph nodes previously. Thank you.
First, I want to ask why you did the CT after the sonomammography. It was diagnosed by sonomammography.
Yes.
And you take the biopsy.
Yes.
So why to do the CT?
We have done the CT as a staging. We would like to assess.
You have a PET CT. You didn't do a PET CT
because we don't have PET CT available at Bahia.
You have a PET CT in Bahia?
No, we don't.
You don't have?
We don't have, except in special situations.
That's why you did this.
Yes.
Okay. Thank you.
In the second case, she didn't receive chemotherapy except for capecitabine, Xeloda.
As adjuvant treatment, yes.
As adjuvant. If we consider it as a new primary, and I think you did, this is not metastatic. You treat her as a new primary, TX in the node, or just only metastasis?
No, we considered her as metastasis, contralateral axillary metastasis.
So this capecitabine is not an adjuvant?
For triple negative. We received neoadjuvant chemotherapy 2 years ago.
Yes.
Yes.
And now you discover a contralateral axilla, you remove it surgically, and I agree with you, of course. She received radiotherapy, I agree with you. But what's the role of capecitabine? If you consider her a new primary, she should receive an adjuvant chemotherapy, taxanes, whatever, if she received anthracycline before. If you consider her a metastatic disease, and you give her capecitabine as a first-line metastatic,
no.
So capecitabine in this case is not an adjuvant.
A pseudo-adjuvant for triple negative was
Pseudo-adjuvant is a terminology that we may agree or may disagree. But for me, you are treating well, you are managing well. But if I consider her another primary, I should give her adjuvant chemotherapy. This is my
معلش انا عندي بس اضافه صغيره. الحاله دي metastatic disease اخر حاله ولا another primary?
We were treating her as a contralateral axillary metastasis for curative intent.
It's not axillary metastasis. So it is a metastatic disease from triple negative primary.
Yes.
Okay.
And we were
if you are treating M1 disease for during the first 3 years of the finishing her adjuvant treatment, you are keeping with all data from Keynote 355, as Dr. Mohammed Magdi said before. You have 3 main treatment options.
PRACA.
To add Bembro plus gem carboplatin, Bembo plus nab-apraxane or nab-paclitaxel, to add taxanes. And you leave taxanes about 2 years. So you can reinstall taxane against with carboplatin or to give gem carboplatin as a systemic control, and the surgery may come after finishing of the systemic treatment, because the main issue in this case is to make a systemic control by chemotherapy, not by surgery.
Okay.
If you are considered this case is another primary, you should also to give a neoadjuvant, because to consider meta-analysis, any triple-negative breast cancer or HER2-positive should receive systemic control before surgery, because the PCR is the detrimental issue to give capecitabine or not after surgery.
Okay.
That's my addition.
Okay,
By
I
any
agree- I
means,
agree with
this
you.
case, or either new primary or M1 disease, you should go for systemic control, as Dr. Hani said.
Okay, I agree with you. Okay.
The rule of surgery in the first or second case?
In second case.
In second case?
Yes.
Metacrinous contralateral axillary.
With a triple negative disease.
Okay.
With a young female.
As I decided in the initial MDT to receive neoadjuvant systemic treatment followed by axillary clearance. Just to receive neoadjuvant treatment followed by axillary lymph node dissection. For the first case?
Second
For
case.
second case?
Yes.
mastectomy.
The
Upfront surgery
patient
followed-
started surgery without neoadjuvant. That's what I said. And she didn't receive gemcitabine containing regimen and received capecitabine post-operatively. That's my يعني ده اعتراضي في الحالة. So far you did your best to exclude the TX disease. And you confirmed that it's metastatic disease during 3 years from the finishing of the primary treatment.
I agree with your point, and we already have done this before in many cases, but I didn't يعني, know why this was the MDT decision for this case. Maybe the axillary she was N1, maybe there's something else I didn't يعني, discuss with the MDT, but this was the MDT decision. But otherwise, I've seen many cases, and we will go for neoadjuvant followed by surgery, and then we will go for pseudoadjuvant.
My last question about the first case. You have a recurrent disease, and you classify as either N3 or M1 disease.
Okay, the first case.
Yes, first case.
Okay.
What's N3? Because in the contralateral axilla, it's not N3. It may be N1 or not.
The contralateral axilla, not the locoregional
Yes.
regional lymph node of the primary side. So any contralateral axillary lymph node should be considered by the NCCN as a M1 disease, not an
Yes.
N3 disease.
Totally agree.
Supraclav lymph node before 2006 was staged as
N3.
M1.
M1.
But
M1 is the epsilon.
After that, after many studies that showing the survival of the patient with pathological supraclavicular lymph node is more than the proved than the metastatic disease, considered to be an regional lymph node. Aiming in our presentation after revision these cases to consider the contralateral axillary metastasis as an regional disease and treated with a curative intent. And at Bahia we have a study retrospective about 50 cases with this scenario, contralateral or contralateral axillary metastasis synchronous metagnous, and waiting the published data إن شاء الله.
أنا ليه سؤال أنا كمان يعني what if we did the MR and in these cases we found a contralateral mass within the يعني within the breast يعني how will the management change from the surgical يعني مش أقصد الأدوية لأن إحنا الأدوية بالنسبة لنا كده لكن أنا بتكلم المانجمنت
the is different 180%.
ما هو ده اللي أقصده ده اللي عايزة إن الناس
It's a very important issue.
هعتبرها بقى another primary cancer.
If you didn't found the contralateral breast mass correlated with the contralateral axilla, you will consider it as M1 disease. As
Yes,
M1 disease, totally different in treatment. She will receive CD46 plus CI as a upfront line.
لا هو حضرتك قول لنا عشان اغلبيه الناس اللي قاعده مش انكورج حضرتك قول لهم بالياتيف او كيوريتيف انتنس بالياتيف انتنس
لو لقينا حضرتك البريست اللي هو الكونترالاترال ما لقيناش البريست ماس اللي موجوده
هنعتبرها ميتاستاتيك
you will consider the contralateral lymph node is M1 disease.
والبيشنت treated with palliative intent
yes.
صح؟
in a palliative intent, but you are not giving chemotherapy in this case. You are giving upfrontly hormonal for a palliative intent, although the patient with nodal score or oligometastatic may be treated more favorably than the visceral disease or pulmonary or bone or brain. But you should allow the trials, MONITOR 2 and 3 and 7, you are go for, or MONARCH, you are go for upfront treatment for this case. The finding in the MRI totally different the case scenario.
ما هو ده اللي يعني انا القصد لما حطينا الكيس سيناريو ده كنت عايزه الناس يعرفوا كده ان هتصرف ازاي لو انا عندي ماس في الكونترالاترال لقيت حاجه انا ما كنتش شايفاها بس شفتها في الام ار وبيوبسيت وطلعت مالجنت او ما فيش حاجه خالص في الكونترالاترال.
Because by this qualification she has a bilateral breast cancer. She should see neoadjuvant treatment and go for bilateral surgery. And by the way,
كانها كيوريتيف انتنت على الناحيتين. الكونديشن برضو اللي ممكن تقابلنا ساعات ان انا وانا بعمل البيت سي تي لقيت بقى ميتاستاسيس في الاذر سايتس في اذر اورجنز ففي الساعه خلاص دي كده اكد لي ان اكيد 100% الناحيه الثانيه دي ميتاستاتيك ولا لا.
That's why Dr. Sahar asked about PET-CT because it may be a detrimental in the management.
بالظبط كده.
Because
one was false positive by MRI. برضه دي مشكله كان ممكن نعمل بام ما عملناش ليه بام فيها؟
في الحال لا يعني لغايه دلوقتي ما عملناش ستاديز اللي هو الاوكلت بريست كانسر اعمل له انفستيجيشن بالبام ولا لا. لان زي ما كنا لسه بنتكلم مثلا عندنا اللوبيولر والدي سي اي اس ساعات بياخدوا زيهم زي السراوندنج لسه يعني احنا معانا حالات وكده ولسه بنطلع ريزلتس احنا يعني بنعمل الليرنينج كيرف بتاعنا لان مفيش كلام هنشوف فيه كتير. فلما
تطلع السنه الجايه
السنه الجايه رد بقى احسن.
عايز اعلق على سؤال حضرتك سؤال very important لزمايلنا الانكولوجيست او النون انكولوجيست. M1 sometimes we deal with as if a sentence of death. She is M1, give her palliative treatment. By the way, palliative means you need to palliate a symptom. If she is asymptomatic, there is no palliative treatment. We shouldn't deny some form of aggressive treatment for those who have a low volume disease. M1 or so is an anatomical classification يا شباب ما تنسوش. We have a lot in our experience أساتذتنا كمان الكبار عندنا ناس biologically surviving with M1 no evidence of disease. سواء براديو سواء انتوا عندكم كمان في خبره.
لا ده احنا كتير كده وانا دايما اقول القلب الحنين دكتوره اميره يجي العينه بتاعتها تريسبوند كويس قوي فتبقى تقول هو ممكن نعمل لها العمليه بقى.
ده it's another issue because we in Bahia if I am thinking as a policy maker جوه Bahia you have a challenge its name is limited resources. So you need to balance between you are having an intent to treat this patient a little bit aggressively to give her a longer, better outcome, or to treat her curatively. لأن كل اللي احنا بنعالجهم يا دكتورة رشا حتى on a curative intent stage 1 disease بيرجعوا لنا بعض منهم metastatic بعد سنتين 3 4. So you should do the bottom line is do your best. Don't be like a judge. Tell her this is going to die, this is going to be palliated. I end my day.
بس ممكن بس أعلق حاجة صغيرة هنا.
اتفضل بيه.
لو العيان فعلا metastatic all over the place and then he is cured, we all know that there is micrometastasis still there. ده number one. Number two, ASCO 2020 the opening session كانت جراحة اللي قالتها وقالت إن ال debulking أو removal of the primary in metastatic has no role at all in the
I contradict this because generally you are speaking right. Some subtypes كان نسيت اسم الراجل كان معانا من شهرين هنا في الراجل المشهور بتاع اليانج البريست كانسر ان يانج وومن ايطالي هو يعني عشان نطلعكم بره الخناقه دي if you have a low volume disease try to do your best. فكره ان انا اشيل البرايمري في ميتاستاتيك بيشنت ديبيتابل. الترايل الوحيده اللي طلعت بوزيتيف تركيا.
انا معاك تماما في ان احنا لازم نعالج العيانين دول 100%. انا I'm not saying treat them as palliative يعني ملوش حل.
Yes.
لكن I'm talking about the role of surgery بس.
ده موضوع كبير قوي يطلع بتهيألي بره القعده.
هو ممكن يقعد ان احنا الديبيت مش هيخلص والوقت، لكن هو البريست مور ديفرنت فعلا. عشان كده طلع الترمينولوجي بتاع الاوليجو ميتاستاتيك ديزيز، واول ما بداوا بيه في البريست قبل اللانج والنون سمول. الاوليجو ميتاستاتيك ديزيز لما لقوا مع الادفانسز اوف تريتمنت السرفايفل بتاعهم تقريبا زي النون ميتاستاتيك، دخل الترمينولوجي ده واتحط له شروط. يعني ايه لو فوليوم؟ خلاص دي ليها شروط والسايتس والنمبر كام، والشرط المهم if you can control the metastatic site then you can cure as a curative not ablative. So مثلا if for example if I have a solitary bone disease I'm sure it is metastatic. اوكي if I'm sure بالظبط هي دي بقى الترمينولوجي بتاعه وليه شروط، والاسمه حطوا في الاي بي سي حطوا ديفينيشن للاورجوستاتيك وعدلوه تاني. لكن اهم من النمبر والسايت if I can control، يعني لو عندي مثلا ستيريوتاكتيك بودي راديو ثيرابي I can control الميتاستاتيك سايت ده properly so I treat it at this case as، وده كان الانديان والتركيش ترايل اللي هم جابوا ريزلت في البريست.
دكتور ماشي طرحا، بس في نقطه مهمه جدا الا وهي الاوليجوميستات ديزيز. احنا عندنا هنا دلوقتي الابديتس اللي عندنا في الناتالي ترايل والموناركي ترايل اللي حتى ما عندهمش ميتس بياخدوا علاج 2 أو 3 سنين CD46 بلس اي وهم ما عندهمش حاجه. That's why ان انا لما هتكلم على patient عندها اوليجوميستات ديزيز I should not ignore systemic control. I should add surgery for the patient، وخدوا بالكم الكلمه دي has a long stability on hormonal treatment. not بعد ما achieve response على طول افكر في جراحه. الارت هنا بتاع الانكولوجي how to introduce your patients in a surgical manner or interventional manner وهيجين benefit منها. The most patient gaining benefit from local control for the patient has a long stability over systemic treatment. Yes, oligo. Because even the not oligo, in the adjuvant setting, you are adding CD46 for optimal event disease-free survival. That's why you should not omit the systemic. If you are going to think with oligo, think with surgery, and don't omit your systemic control, because some clinicians make this is a pseudo-adjuvant, this is not oligomastatic after surgery, and give the patient chemotherapy, and give actually radiotherapy post-mastectomy, and omit the systemic control. That's why my main contradiction against the surgical management of oligomastatic and the discontinue the systemic control.
بس كنت عايزه
Okay,
حاجه
now we
اخيره.
come to the next presentation.
انا بس عايزه اقول حاجه صغيره اخيره، ان هو هدف البرزنتيشن بتاعتنا النهارده هي الايديا بتاعت هل ال contralateral axillary metastasis will be considered as M3 زي ما السوبر كلاب الابسيلاترال سوبر كلافيكولار lymph nodes كانت قبل كده M1 ودلوقتي بقت M3 according لديتا كتير احنا قريناها كلكم عارفينها. كلهم اساس ان فعلا اللوكال كنترول او الاجريسيف كنترول whether براديوثيرابي او سيرجري او وات ايفر بيحسن جدا او بيمبروف الاوفرول سرفايفل لذوز بيشنتس. regarding systemic treatment I agree طبعا with دكتور محمد ان احنا lymph node excision or radiotherapy على الليمف نودز. Yes. No, axillary lymph node dissection.
You should dissection. You have
Yes.
to leave.
Yes.
This will be the quality of life.
We have many papers and okay. Yes. Yes. لا لا احنا
You are listing very hot doubtful topics. This is the problems of breast.
Yes.
واضح ان انتوا have a good experience وان هو انتوا عاملين presentations على الحاجات اللي فيها debate وده عشان كده discussion very hot يعني مش هتوصل.
احنا بس بن clarify some points. Thank you.
Next presentation will be about the patients presenting with metastatic axillary nodes with no identified breast lesion. Okay, right. Yes. Will be by Dr. Asma Zenhom, Dr. Nisma Salah, Dr. Ashraf Naguib, and Dr. Muhammad Abdelaziz.
دكتور أشرف موجود؟ تخش على طول؟ Okay. Good afternoon, everyone. I'm Muhammad Abdelaziz, Assistant Lecturer at Azhar University. Today we have a talk about occult breast cancer. We have two cases to be presented. Ms. Latifa is a 44-year-old female with left nipple changes after an excisional biopsy 7 years ago with no other abnormalities. Ultrasound showed left axillary mild enlarged lymphadenopathy that seems to be reactionary for follow-up and no clinically or radiologically apparent breast masses. The second case is Ms. Nusa, is a 50-year-old nice lady came to the clinic with a complaint of a lump in the right axilla. Clinical examination revealed a large right amalgamated axillary lymph node with no palpable breast masses. So let's start with Ms. Latifa.
The patient come for screening. Mammogram was done showing left breast retroareal post-operative changes in the form of distorted parenchyma, dilated nipple, and increased areolar skin thickness. No suspicious microcalcifications or speculated masses. Breast ultrasound was done, revealed pathological enlarged axillary level 1 lymph nodes showing uniform increase of cortical thickness and effaced fatty hyla. Some are globular in shape.
Occult breast cancer refers to breast cancer not detectable by physical examination or imaging tests such as mammography or ultrasound. It started with the explanation of William Halsted back in 1907 when he found a lot of patients with axillary masses without a primary breast cancer. Then it was then reported in 1973 with a phrase of occult breast cancer mentioned in a case report of women with axillary nodules in Germany and the United States. Occult breast cancer accounts for 0.1 to 0.8% of all newly diagnosed breast cancer, and the incidence has not decreased with the improvement in breast imaging. When we revised the NCCN guidelines to evaluate a suspected metastatic malignancy in the occult primary, we should do all physical examination and laboratory routine lab and images. Then we do a fine needle or true cut biopsy. We can have an epithelial tumor, lymphoma, thyroid carcinoma, melanoma, sarcoma, or germ cell tumor, or non-malignant disease. She could have a TB, she could have an acute infection, etc. Pathology.
Carcinomas are positive for cytokeratins. Melanomas are positive for S100. Sarcomas are positive for Vimentin. Lymphomas are positive for LCA. Neuroendocrine carcinomas are positive for chromogranin, and germ cell tumors are positive for PLEB and FET protein. For the breast, lesions of breast origins are positive for cytokeratin 7, negative for cytokeratin 20, positive for GATA3 and mammoglobin, and positive for ER and PR. Here for our case, axillary lymph node true cut biopsy show metastatic carcinoma, positive for GATA3, strong positive for ER, PR, and negative for HER2. For the breast, breast shows invasive lobular carcinoma grade 2.
Should we do a HER2 test as a marker to diagnose an occult primary breast cancer? This is a question to the panel and the great audience. No, that's true, because it lacks specificity to breast cancer, and only 18 to 20% of breast cancer patients overexpress this protein. And we all know that it has a prognostic and predictive value in the management of breast cancer. Okay, we have an adenocarcinoma here. It's axillary lymph node. We did metastatic workup, mammogram, and here we come with the mammogram.
Value in mammogram in 1992, the value of mammogram in normal breast examination was addressed in 17 patients with normal breast examination and palpable axillary lymph node. It found that 17 patients had abnormal breast mammogram. However, many occult no palpable tumors are missed because of their relatively small size. In one series, 30% of occult breast primaries were 5 milliliter or less in diameter, and because they are obscured on mammogram by dense fibroglandular tissue. Value of MRI, breast MRI is more sensitive than either mammogram or breast ultrasound for detection of invasive breast cancers. Data from several small series suggests that breast MRI can detect primary breast cancer in approximately 75% of women who present with axillary adenocarcinoma, poorly differentiated carcinoma, and a negative clinical examination and mammogram. Furthermore, the identifications of a primary breast cancer by MRI may facilitate breast conserving surgery instead of mastectomy. After TrueCut was taken consideration in case of pathological axillary lymph nodes without breast lesions, TrueCut biopsy should be taken instead of fine needle aspiration to apply tissue core biopsy for proper diagnosis and to avoid false negative results. After the pathology reveals that the pathological lymph nodes were metastatic adenocarcinoma from breast origin, immunohistochemistry, luminal breast cancer, contrast MRI was done to detect any breast enhancing lesions. MRI subtracted images showing left retroareolar segmental clumping non-mass enhancement in area measuring about 4 cm. Pathological left axillary level 1 lymph nodes, right breast upper outer quadrant well-defined homogeneously enhancing mass lesion with non-enhancing internal septations pathologically proved to be benign fibroadenoma. Time intensity kinetic curve were done and revealed type 2 plateau kinetic curves.
So MD decided a systemic treatment with neoadjuvant chemotherapy followed by center quadrantectomy and axillary clearance. We have a clinical stage of T2N1M0 disease. The panel and the audience, do you agree with the MD decision or do you have any disagreement? We have that metastatic workup, it revealed an M0 disease. Okay.
And they did not do a pathological يعني اللي اتشالت من كام سنة في الأول most probably this is a very low grade luminal breast cancer واتشالت على إن هي fibroadenoma وما اتحللتش وده الريكورنس بتاعها يعني لأن سوري ما أنا بقول لحضرتك لأن هو قالت إن هي كان عندها history of retroareolar mass removal فموست probably this is a very low KI luminal breast cancer, luminal A very low, most probably وده اللي فاضل لكن
I agree with you دكتور أحمد.
لكن هو السؤال بقى للباثولوجيست هنا لو أنا خدت بايوبسي أنا بسرح أنا ما عنديش data could we do a Ki67 for this biopsy على ال axillary lymph node and then act upon with hormonal يعني if she is Ki67 is it possible أنا ما عنديش معلومة وطلع 5 would you still go for chemotherapy as neoadjuvant ولا surgery and then go for hormonal? Sorry?
For me, if she has a low key,
مش على البريست.
You do not have breast by today, صح?
Yes, we don't have.
Suppose it's a one disease, you have a low proliferative luminal disease. Everybody knows in the room it is badly responding to chemotherapy. And you can see in several cases, neoadjuvant chemo, you will have a residual tumor burden of 2 or more. This is a room for, do we have any data to suggest induction AI?
لا مش قصدي كده sorry. Can you do a Ki67 test on the metastasis مش على البرايمري tumor أنا بتكلم على الأكزيلا.
هو الحقيقه اصلا الكي اي 67 is a matter of debate وفي انتر اوبزرفر variability very very high لو خدنا من البرايمري، فاذا كنا هناخد من الميتاستاتيك سايت اعتقد ان هو مش هيبقى اوف فاليو.
بس انا بتكلم ان this case most probably she is a luminal disease from the start وخدت كام سنه عشان يجي لنا الادله.
عايز تعمل ايه يا احمد؟ عملنا الكي، عايز تعمل ايه؟
ما هو انا مش موافق على ان انا ابدا كيموثيرابي اب فرونت دلوقتي لو هي ليومن. فاهم قصدي؟ ان انت لسه بتقول
I wish to have as early as we can systemic treatment. The question here, she deserves chemotherapy? Yes or no? She has an N1 disease. عمرها كام سنة؟
44 سنة.
بس
44 سنة.
سؤال، هو جبته منين تي 2؟ تي اكس.
لا ما we have found a primary with
ده اللي انا عايز. الام ار اي شافها. الام ار اي شافها.
ايوه. Did you take a biopsy؟
No, we didn't know.
But
we have an
مش قصدي،
enhancing
ما ممكن يبقى distortion برضه. انا مش
retroillular enhancing mass.
لا بس هو بيقول لا.
We did it.
طب خلاص يبقى سؤالي الاولاني unvalid. لا بس هو اهو طب خلاص اوكي. لا بس عشان
هو السؤال في ديسكريبنسي لزمايلنا بتوع الباثولوجي، في ديسكريبنسي بين البرايمري والليمف نود ريجاردنج كيل كي اي. تو ماي نولج ان يوجوالي اتس ذا سيم. لو هنا هاي كي اي هتبقى هنا هاي كي اي، لان في بعض ديسكريبنسي مثلا ممكن يبقى في الاي ار والبي ار، بعض ديسكريبنسي في الهير وان كان اقل شويه. هل في ديسكريبنسي؟ لان فكره الدكتور احمد مجدي ان لو هي انا خدت من الليمف نود وما عنديش برايمري وطلعت لو، هل كاي ديبند انا اقدر احلف ان البرايمري كان لو ولا في ديسكريبنسي بينهم؟ لان فور اور نولج ان دايما الكي اي في الاثنين واحد.
معلش هو يا جماعه هو كير 7 اتس رول. احنا هنرجع للبيشنت دي بري مينوبوزال بيشنت خلاص عندها تي 2 ان 1 ديزيز. يو ار فور oncotype DX to give a chemotherapy, adjuvant chemotherapy, or to give hormonal, because according to Taylor's X trial, this N1 disease and she has a premenopausal
This is a
profile.
clinical staging. That's not a pathological staging. T2N1 it's clinical. We have a mass retroillular 4 by 4 centimeter
Yes.
and pathological lymph node and axilla mobile. So we have a clinical T2N1. We didn't do any treatment yet.
ما احنا قلنا بقى احنا
The
خلاص
MDT
خدنا عينه يا
decided
دكتور
neoadjuvant.
محمد.
Do you agree or not?
احنا خدنا عينه من البريست ماس وبروفن انها
من
T2
Yes.
invasive carcinoma.
Invasive lobular.
Lobular carcinoma.
Okay.
You are allowed to go for oncotype DX for those patients because
Upfront
she has
before surgical before treatment you do oncotype DX before
after treatment.
Okay,
If
should we
you-
do a systemic chemotherapy
you-
before surgery or not? The MDD decided a neoadjuvant chemotherapy. Do you agree or not?
You may relate to a case 7 because it is valid. If it's less than 10, it will be more accurate. If it is more than 10, 11 equal 14 or 40. Yes. Yes. You may offer hormonal treatment upfrontly.
لا طبعا هتاخد كيمو طبعا. She's N1. According to the oncotype Taylor X study,
Taylor X trial.
she is premenopausal.
No, it's post adjuvant, post surgery, not a neoadjuvant setting.
بالظبط كده. الفكره جت ان هي MDT قالت ان هي عينه صغيره في السن. Mostly she will receive chemotherapy after surgery. So why not we give her before surgery and we clinical examine the response.
To keep with the guidelines. You are giving a neoadjuvant chemotherapy for T3, T4, N2, N3. It's a neuronal type. If you have a triple negative patients, it's another issue.
هو ممكن اقول لحضرتك يا دكتور صبري حاجه. هي احنا ساعات في التيومر بورد يعني لو ما بيجي حاله تي 2 او كده بتبقى بالبريفرنس بتاع السيرجن. لو البريست صغير وهو حاسس انه لو شال هيسيب البريست ديفورمد برضه كده، ممكن ساعات بنديها الترايل ان هي تاخد مع، انا عارفه ان الحاله دي عشان هي لوبيولر ولومينال كانسر ممكن ما تستجيبش قوي، بس في احتمال برضه انها تصغر شويه، يعني فور كوزماتيك بيربسز، مش عشان هي لوكالي ادفانس ولا اي حاجه. بس وهي تي 2 بس هاي تي 2 يعني فيري يعني ادهرنت للنيبل او قريبه قوي من النيبل، فممكن ده كله يتحسن بعد النيو حتى لو هي تي 2 ممكن. ما انا عارفه والله عارفه عشان انها لوبيولر ولومينال مش نعم يعني بيبقى على الاقل ممكن تعمل سنترال وكوادرنتكتومي وتتشال، بس مش هيضطر بقى الجراح يدخل، يعني كل ما صغرت كل ما هو شال اقل. فساعات بنديهم الترايل دي حتى لو هي تي 2، وهي هاي تي 2، هي 4 سم وشويه.
It's not wrong to give her chemotherapy. But it's not a mandatory to give her chemotherapy.
لا not mandatory الا لو في امل انها تعمل conservation بعد كده، بالذات ان هي عندها 44 سنه.
It's be mandatory with our knowledge, because mandatory means we are waiting for pathological complete response.
لا في دي احنا عارفين ان هي مش هتوصل، مش aiming فوق كده، غير قد ان هي تبقى downsizing السايز of the tumor بس.
Okay, you can. اتفضل.
في تكنيكال ايشو بس. Further data about this patient are missing because she lost follow-up in our Bahia hospital and she was treating in another hospital, so we don't have data about the pathology after. Okay. Okay, for the second patient, we have Miss Nusa. She, as we said before, she has a right amalgamated axillary lymphadenopathy.
Mammogram was done, showed bilateral heterogeneous fibroglandular pattern with no suspicious microcalcifications or speculated masses. Breast ultrasound was done, revealed pathologically enlarged globular axillary level 1 lymph nodes are seen showing effaced and lost fatty hyla. No suspicious solid or cystic lesions in the breast. True cut biopsy was done from the lymph node. After the pathology revealed that the pathological lymph node were metastatic adenocarcinoma from breast origin, ER, PR were positive, HER2 negative, KI 67, 40%. Contrast MRI was done to detect any breast enhancing lesions and revealed pathological axillary level 1 lymph nodes are seen with no T2 weighted images, abnormal signals, or distorted parenchyma. With MRI contrast sequence with the subtraction, but revealed pathological axillary lymph nodes level 1 with no pathological mass or non-mass enhancing lesions. If there are for contrast enhanced sonomammography in the diagnostic setting, the sensitivity has been shown to be equivalent to MRI among women at increased risk of breast cancer, although it hasn't been compared with MRI in women with dense breasts. However, it may be superior to mammogram only. As an example, in 2017 study from Japan, this imaging technique detected substantially more cancers in women with dense breasts than mammogram alone. This technique may have a role in supplemental screening. Such as this case, 50 years old female come for screening, detect which has heterogeneous breast cancer, and after contrast enhanced mammography is revealed right upper outer quadrant non-mass enhancing lesions, which is detected with MRI, and the MRI didn't add any informations. But we prefer MRI because it can detect any deeply lesions which didn't detect by mammogram.
So we have here a diagnosis of occult breast cancer. According to the DNM classification, the 8th edition, we did a metastatic workup and it revealed an M0 disease, and we have a clinical stage of T0N2, stage 3A, AGCC 8th edition. So my question to the panel, what are the different treatment options for this case? I would like to hear from surgeons as well, if we have surgeons here.
Update me about the age of patient. عندها كم
She's 50 years.
50 years, pre or post menopause?
Pre-menopausal.
The ERPR receptors.
ERPR positive, HER2 0, KI 40%.
Yes, she's luminal type B breast cancer
Luminal
with
B, yes.
N2 disease.
N2.
That's Dr. Bullis what said. She needs a new adjuvant chemotherapy. Then for this
We have an occult breast cancer. We don't have
Yes.
we don't have a lesion in the ipsilateral breast. What do you recommend for the treatment of the ipsilateral breast? Okay. Okay. We don't have a mass in the breast. It's an occult disease.
Dr. Muhammad, you won't hear from us that you are agree for mastectomy for normal breast.
We have different treatment options, and I will tell you.
Maybe a mastectomy a solution, but with a detailed imaging for the breast, I think the mastectomy has no role in this case.
Okay. Okay.
Okay, Muhammad. Yeah, we have three options: whether to give radiation to the breast, or to give to do mastectomy, or to do outer quadrant excision.
We don't have a mass in the upper outer quadrant. We don't.
These are the regimens for occult breast lesions with axillary metastasis.
Okay. Okay.
This is another option, yes.
As the panel said, we have the option of neoadjuvant chemotherapy followed by mastectomy, then radiation because you have an N2 disease, or we could have a neoadjuvant chemotherapy followed by axillary clearance, then whole breast irradiation, and the last option is neoadjuvant chemotherapy followed by axillary dissection and the observation for the ipsilateral breast. Actually, N2. The optimal treatment for this case for the ipsilateral breast is controversial because we don't have any prospective phase 3 trials address that issue. For the observation observation of the breast without definitive local treatment is generally not recommended in most cancer institutes because there is a risk of tumor recurrence and possibly decreased survival. Here you can see in this table a compilation of published data on local recurrence in patients with occult primary, not undergoing surgery, and the percentage is almost 50% of patients develop local failure if we don't have any local treatment for the ipsilateral breast. In this Kaplan-Meier curve, at a study clinical benefit of mastectomy versus observation, you can see there is a dismal outcome regarding a patient who didn't do mastectomy regarding disease-free survival and overall survival as well. Mastectomy versus irradiation. Actually, the standard approach for occult breast cancer is mastectomy at the time of axillary dissection due to breast malignancy will be found upon histological review of mastectomy specimen in approximately 65% of patients. Here you can see in this table studies from 1954 to 2012 with almost 65 patients has a breast lesion in the specimen after they did mastectomy. If we choose whole breast irradiation, there are no randomized trials comparing mastectomy versus irradiation, and the only available data are from retrospective studies and case series. The local control rates of whole breast irradiation ranged from 73% to 100%. Here, this study it has a purpose of evaluation of treatment outcome and prognostic factor in patients with occult breast cancer. It included 95 occult breast cancer patients retrospectively analyzed into 3 cohorts. Group A had mastectomy plus or minus irradiation. Group B had axillary clearance plus whole breast irradiation, and Group C had axillary clearance alone without any local intervention. The pathological features of patient who did mastectomy had 20 patients of the 64 who did mastectomy had cancer in their breast. Either it was in situ or it was invasive. The median follow-up of this study was about 40 months, and there was a significant difference regarding the local relapse-free survival and the recurrence-free survival between the local treatment and the observation. And you can see from the p-values there was no significant difference between لا استني 3 دقايق 3 دقايق بالظبط. ثلاث دقايق. دقيقة.
For 3 minutes, please.
أنا خلاص والله، بس هو أنت عملت إيه؟ مش دي. تاني. كده في 5 دقايق كمان. Okay. There was a significant difference between people with a patient who did local treatment versus observation, and there is no difference between whole breast irradiation and mastectomy. Here you can see from the Kaplan-Meier curve the yellow line representing the observation, and there was a significant difference between local failure regarding relapse-free survival, breast cancer-specific survival, and local relapse-free survival. When they did a subgroup analysis, they found that patients who had a lymph node positive more than 4 lymph nodes had a dismal outcome regarding the recurrence-free survival and breast cancer-specific survival, and also the ER negative versus ER positive. So we can conclude here that patients with local primary must do a local treatment, either it was mastectomy or whole breast irradiation, and lymph node positive with more than 4 lymph nodes have worse outcomes than N1 disease. So the MDT cited systemic treatment with neoadjuvant chemotherapy followed by mastectomy and post-operative radiation. We have a clinical stage of T0, N2, M0, and currently the patient on neoadjuvant chemotherapy with good partial response. So my take-home message, all patients should have a local radical treatment. Optimal treatment for ipsilateral breast lesion is currently controversial, and the standard approach is mastectomy at the time of axillary dissection. For women who wish to preserve their breast, whole breast irradiation is an acceptable treatment option. Observation alone versus local treatment is not recommended. MRI has proven to be superior to detect clinically an apparent breast lesion. Studies to compare between MRI and the contrast-enhanced mammography are needed, and with this I end my presentation, and thank you so much.
I want to ask you, you didn't do contrast mammography or PEM to this patient? Or it was
MRI.
negative?
We did MRI and we didn't find an occult breast lesion.
So you didn't shift to others? Okay.
One question please. Yes. معلش سؤال أخير. دكتور محمد، الحالة اللي عندك N2 disease, which is more important for you as a practitioner in the field of breast cancer, the local recurrence or the systemic recurrence? Because this patient presents with N2 disease, either TX or whatever, but she has an N2 disease. And what is your current recommendation now? Not for the papers from 10 years ago, for follow-up the patient receiving AI only. Because
actually, I didn't put a prognostic data in occult breast cancer because they are old. They didn't include further treatment with options we have now, like CDK4/6 inhibitors for adjuvant treatment. And also they didn't include the 7 years hormonal treatment or 10 years hormonal treatment. So that's why I didn't include prognostic data for occult breast cancer. They are all old. For my opinion, I think this patient, as she has a Ki-67 40% lymph node N2 disease, more than 4 group of lymph nodes, she needs an intense adjuvant treatment, post-operative radiation, and dual agent hormonal treatment abemaciclib, aromatase inhibitor, and ovarian suppression because she is premenopausal.
Yes. That what I did to know. ده اللي كنت عايز اسمعه. لان الداتا القديمه بتاعه الماستكتومي او اللومبكتومي او الاوبزرفيشن مبنيه على داتا كان من 10 سنين فاتوا. بعد ما تابعت 10 سنين زيهم ان العيان ده ما يحصلوش ريكارنس على ان هو بياخد AI لوحده. دلوقتي the practice it changed. We are giving the patients combination of AI plus CD46 to prevent the recurrence in addition to surgical maneuver. So you can now relay for more systemic control with less destructive surgery for those patients because you are giving a dual blockage for AI plus abemaciclib or recently ribociclib for the adjuvant treatment. I want to present last presentation. Thank you, Mohammed Hussein. دكتور نسمة صلاح. إذا مش معانا نضارة مش معلش. I want to pathology proven breast cancer with solitary bone mets prepared by دكتورة مي مجدي. يا جماعة السكرين. بروفيسور ياسمين هاني، دكتور إسراء سلام، دكتور مي مجدي راديولوجيست، دكتور ياسمين هاني surgical oncologist, دكتور إسراء سلام medical oncologist. You can go to
we will present a case of pathological proven breast cancer with solitary bone mets. A female patient, 33 years old, premenopausal, with no comorbidity, has negative family history of breast cancer, presented to Bahia Hospital with right breast mass at 2020.
Conventional solar mammography was done, revealing the right upper outer quadrant speculated high dense mass lesion, harboring suspicious fine polymorphic microcalcifications with global asymmetry. The whole disease measuring about 10 by 6 centimeter, with ipsilateral pathological axillary lymph nodes in level 1 and 2, more than 3 lymph nodes. So metastatic workup was done with CT chest, abdomen, pelvis with contrast, revealing free chest and liver with the right iliac, paracycloiliac osteolytic lesion with cortical eruption and related soft tissue component measuring about 2 by 1.7 centimeter. Bone scan was equivocal. PET-CT was done, revealing right iliac bone lytic lesion with SUV 3.3 and the local disease with no other metastatic lesions. Advantage of PET-CT over CT, it provides morphological data and functional information. Better accuracy in detecting regional and distant metastasis, especially in lytic bone metastasis, than the bone scan. It can identify cases with oligometastasis which may benefit from local ablative therapy such as surgery, metastatectomy, or stereotactic body radiotherapy. Biopsy was done revealing invasive duct carcinoma grade 2 with ER/PR positive, strong positive, and HER2 negative. Should we take a biopsy from solitary bony lesion or not? Actually, when imaging is not inconclusive, not conclusive, and to confirm the nature of the disease, especially in cases of relapse, for the change of the tumor behavior, other possible differential diagnosis other than bone metastasis.
MDT was done, and we considered the case as oligometastatic breast cancer, clinically T3 to N2M1 with solitary bone metastasis, according to the definition of oligometastatic breast cancer, which is up to 5 lesions, and which is debatable in another studies which mentioned that it may be 3 metastatic lesions. The lesions shouldn't be at the same organ, but all should be amenable for ablative treatment. The good prognostic factor in our case is being luminal disease, bone-only disease, single-site metastasis, and synchronous metastasis, not metachronous. The cornerstone of management of oligometastatic breast cancer is by confirmation by radiology, then if possible metastatic tissue from the metastatic site, Then MDT decision to decide the most appropriate line of treatment and plan. Then to start the first line systemic treatment. After this, we can do ablative local regional treatment للمetastasis or surgery للprimary tumor, and there is ongoing trials regarding circulating DNA and its benefit in oligometastatic breast cancer definition. So in this case, which is oligometastatic breast cancer to bone, we have systemic treatment with either old or new drugs, local treatment with surgery or ablative radiotherapy, or surgical treatment to the primary lesion. Regarding systemic treatment, in such case, I'm asking about what is the most appropriate line of treatment. Endocrinal treatment alone, does CDK4/6 inhibitors have a role in this case, or chemotherapy? The guidelines in NCCN published in April 2023, it defines that the first line metastatic breast cancer benefit with addition of CDK4/6 inhibitor to either EI or fulvestrant. Also, there is many studies done regarding the role of CDK4/6 inhibitors. There were 4 case reports similar or almost similar to our case, used first-line ribociclib with local regional treatment and achieved CR with favorable safety profile. Many trials done regarding first-line CDK4/6 inhibitor as the MONALEESA-2, MONALEESA-7, MONARCH 3, which showed all benefit in progression-free survival, overall survival more than 10 months. As regard Bahia Hospital, where is CDK4/6 was not available, we decided to give the patient AC by 6, which is mentioned as treatment in neoadjuvant as category B and NCCN guidelines.
Actually, on follow-up CT, after 3 cycles of chemotherapy, more sclerosis of the lesion. After 6 cycles of chemotherapy, almost complete sclerosis of the lesion and resolved soft tissue component, denoting favorable response to treatment.
Now the question is primary surgery beneficial in oligometastatic breast cancer, and who is good candidate for it? In few of recent clinical studies, there is emerging evidence that removal of primary tumor and axillary lymph node dissection is associated with improved survival and quality of life by decreasing tumor burden, tumor-related symptom, and removing the risk of new onset metastatic illness. The surgical approach includes resection of primary tumor and resection of metastatic deposit to complete eradicate the disease. There is growing evidence that some subgroup of patients may benefit from primary locoregional treatment, including younger age, less tumor burden, oligometastatic disease, especially bone-only disease, favorable molecular type like HR positive, HER2 negative, and those who respond well to initial systemic therapy. These studies showed that some studies say that there is no difference in the survival, and some showed improved survival after surgery. And after MDT decision, we decided to perform breast surgery. A patient underwent MRM at 2021. The pathology was T2 breast lesion into axilla and 50% viability with surgical margin free.
And the question now is what next? The next steps, as we mentioned, we should do local control for the bone lesion as by either surgery or radical radiotherapy, post-operative radiotherapy for the breast lesion as local control of the primary, and systemic treatment. There is many studies mentioned the role of radical radiation therapy in the oligometastatic breast cancer, and most of the studies showed better progression-free survival by the ablative or stereotactic body radiation. But there is another study about stereotactic body radiotherapy. The study didn't show any improvement of progression-free survival and overall survival, so phase 3 trial of this study was omitted. There is also many studies done for oligometastatic disease as whole, but SAPR COMET trial done included the breast cancer, and it showed durable improvement in overall survival and the progression-free survival with least side effects. The case was discussed again by the multidisciplinary team, and we decided to give local breast radiotherapy as adjuvant, local ablative radiotherapy to the iliac bone, and to give adjuvant hormonal treatment in the form of tamoxifen LHRH agonist according to NCCN guidelines in April 2023, which mentioned tamoxifen Zoladex as adjuvant. So the question to the MD, to the panels and the attending professor is, should we give TAM LHRH agonist or AI HLHR agonist in an evaluability of CDK4/6? The second question is, for how long? 5 years, 10 years, or lifelong? The third question is, what if the patient seeks pregnancy?
دكتور محمد مجدي يكون معاكم عشان ايه يبقى يساعدكم شويه. First to say, I'm not agree at all to give a chemotherapy with a patient with M1 disease. As I said before, M1 disease make you do a surgery or a radiotherapy, but not changing your mind about systemic control. You give a chemotherapy because it is maybe oligometastatic and named this treatment as a neoadjuvant. It's not a neoadjuvant. You are giving chemotherapy for M1 disease, and by all trials, Palomas and Malisa and Monarch trial, it's not allowed for any patient to receive chemotherapy for M1 disease because it will impact the subsequent hormonal treatment, as happened with palbociclib. That's why the resistance of palbociclib is a little bit inferior than ribociclib and abemaciclib. All the patients received first-line treatment for M1 disease, ERPR positive, should receive by ribociclib because plus AI, because there is OS benefit and PFS benefit, and this mature data, and or abemaciclib plus AI. If you are going to do a surgery, but for the patient with long stable disease over time, you can do a mastectomy or whatever, but don't finish your treatment modalities within 6 months to give hormonal, to give chemo, then surgery, then hormonal, and ask again about the adjuvant criteria of the patient with M0 disease. It's a tricky question. It's not a proper question. You should ask if the patient is continue or resuming CD4/6 after that struggle or not. And the answer is yes, should go for life, to go for AI plus CD4/6, not for time only or AI. For the pregnancy, she is metastatic patients, she receive CD4/6, and you can go for preparing for pregnancy, but you should know that you'll omit hormonal treatment, either tamoxifen for those patients. She's not M0. She's a metastatic patient by definition. And last comment, you should biopsy the bone lesion because it's a medical legality. If you have a solitary bone lesion defined by PET-CT, you should biopsy the patient because after finishing the response, there is one of the family told you there is no metastasis. She is not metastatic.
If you allow me to comment, thank you. So the first question was, we don't have CDK4/6 in Bahia. So as you said, definitely you're 100%. Sorry? عارف هحولها عندكم. اوكي. اوكي ما احنا نسأل نعمل ايه هنا؟ ما هو ده السؤال. radiation recall phenomenon with the doxorubicin and radiotherapy. Yes. But then خد بالك انا معاك في الحتتين فانا بشتغل دلوقتي بهي اوكي يس بس my question to دكتور محمد بعد اذنك حضرتك قلت ان احنا ناخد بايوبسي بعدين
لا بالعكس قرب الميكروفون.
طيب الكويستشن هنا حضرتك لما حضرتك بتقول ناخد بايوبسي من البون I do agree بس our colleagues من الباثولوجي will tell us that the decalcification it's very tedious process and could affect the outcome of the disease. So my question here, would you like to start الأول retrograde diagnosis, meaning that I would give her the hormonal treatment, whatever we agree upon, and then follow up the bone lesion. If it disappears, then we're doing well. And then we could go think because I love the idea of know that you are controlling the disease first before deciding to go for surgery or whatever. So would you like to do it in a retrograde way, that we give the treatment, follow up in 6 months the bone, and if it's decreasing, then we could be treating her as oligometastatic and start thinking and debating without getting the biopsy. If she's increasing, then I will go for a biopsy because it might be a heterogeneous disease and we go on for the debate.
Dr. Mohammed, Dr. Ahmed, you're a very good question. Let me ask in another way to answer your question. If you found this case with a multiple disseminated bone mets,
okay,
are you going to go for a biopsy or not?
No.
Yes, that's my take. So if you are going to see disseminated bone mets, the cardinal sign of any imaging is multiplicity. If you have a solitary lesion in the pelvis, you are in a very unique position. You should specify this lesion not for diagnosis but for staging. You should confirm this site is M1 disease, because if you with no definition, yes, it's accessible.
لا بس الباثولوجي فين؟
In this case, you can do it as a bone marrow biopsy. It will be so easily.
ايوه لو ليها soft tissue component fine بس انا بتكلم على الباثولوجيست يعني الحته دي we have to discuss. Very bad كمان الاوتكم بتاعها مش احسن حاجه.
It's enough Dr. Ahmed, enough to say it's a malignant site.
طيب هقول لحضرتك على حاجه ثانيه. طب لو
I
انا
don't
بفكر
want to have a ERPR assessment for
لا
this
لا
site.
100%
Enough for me to have ERPR positive or even it's a positive site for malignancy.
طب clinician wise او clinical wise, what if we did alkaline phosphatase؟ ما حدش يهاجمني it's non-specific at all 100%. انا بقول من دلوقتي it's non-specific. بس كده. لأن I had the same situation in a patient with PET CT البون منور و SUV 19 والست no complaint alkaline phosphatase normal.
If this positive is confirmation for metastasis.
بس كده.
No.
لا 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 لا.
So,
it's non-specific, absolutely non-specific.
My brain. If you have a solitary bone mets accessible for biopsy, you should define it from the start.
Okay.
Because in the pathway of the patients, the patient missed her way for a chemotherapy and for a surgery and for asking about 5 years or 10 years because she's not metastatic now.
No,
That's why my message here. You should define the solitary mets if it's accessible by biopsy to guide the patients for a proper treatment and didn't forget this site because it's M1 disease. Actually, what's happened in this case have a good response and we are now discussing to give 5 or 10 years for AI only without CD46.
بس رأي حضرتك هنا if we went for this single site we gave her stereotaxis, for example, would you still go for 5, 10, or lifelong? Because I would love to talk about this question.
Okay, we can go back to your question to the
I hope.
actually patient. Go back to the, yes, the 3 questions. What's actually happened, this patient underwent surgery. I don't know why modified radical, could be conservative at least. Also, we should have, you have bit in the beginning, and you should have another bit to be, you don't mention to have another bit after treatment, to be sure that the lesion had been ablated, at least to have another bit scan, and to be sure that she didn't develop another metastatic lesion. Suppose that everything is okay, and the lesion had been ablated, and now you are asking about to give TAM, LHRH, or AI. If you go back to SOFST and TICS trial, and most of trials, we just mentioned that AI plus LHRH are more suitable with better progression-free survival than tamoxifen LHRH for high-risk patient. If we consider this patient as oligometastatic and manage her as high risk, of course, AI with LHRH. Second question, for 5 years or 10 years, to come back to the data again, if you are treating hair an adjuvant and considering hair a high risk, of course, more than 5 years is better for node-positive disease, high-grade disease, and younger patient below 35 or 40 years, you should use extended adjuvant, either 5 years AI, and then to continue with Novadex or whatever, or even Novadex for, if you don't have AI for more than 5 years, we have evidence about. If she seeks a pregnancy, of course, as Dr. Muhammad mentioned, she is under hormonal treatment. Even tamoxifen single agent associated with about 20% teratogenic effect. You have to stop treatment. You should discuss with the patient how it is urgent for her. At least to go controlled for hormonal therapy for a while. We don't have exact for 2 years before thinking to stop treatment and to get pregnant. But at any moment, if she got pregnant and she insists to continue, of course you have to stop the hormonal treatment.
بس أبي سؤال للبانelists, would you go for 10 ولا lifelong ولا 5? I'm going with lifelong.
Yes. For her.
Of course. بس I mean, لأن أنا بس المسج اللي عايز أوصلها للدكاترة إن once metastatic أنا من رأيي it's always metastatic. There is a micrometastasis. It has been proven in many trials في كل الكانسرز.
هتبقى الانسر till progression.
بس yes. Sorry. ولا هخاف.
قد ايه بالمناسبه دلوقتي؟ يعني
مستحيل انا اخاف اوقف.
لا الحقيقه انا اتفق مع دكتور احمد مجدي ان انا ما اقدرش اوقف انا حد لايف لونج. في بس نقطه مهمه لان في نفس السيناريو ده حصل معايا بالظبط. عيانه كان عندها ايزوليتد بول ليجن ظاهر في بيت سكان، عملت لها سي تي ويز بول ويندو، قال لا ما فيش فيها حاجه، والعيانه دي كملت وعملت سيرجري وكملت التريتمنت بتاعها كله، ولحد النهارده ما حصلش اي ليجن خالص، يعني لغايه النهارده هي ديزيز فري. نفس السيناريو ده، فما ننساش يعني لو انا مش هقدر اخد بايوبسي على الاقل اعمل سي تي ويز بول ويندو طالما ده ايزوليتد بول ليجن. ممكن يساعدني يعني.
هتبان في البيت بس الليجن دي والله ممكن انا مع حضرتك انها لازم تبقى بايوبسي، لان فعلا الليجن اللي هي موجوده دي ممكن تكون بون سيست. فيها حته بس والله انا لازم نعمل لها بايوبسي عشان فعلا لا this is not a high risk patient خالص. لا دي هي بيشنت بالعكس، دي احسن كاتيجوري في الكانسر بريست. هي بس المشكله في البون ليجن مش اكتر من كده. بس فعلا لو ما عملنالهاش بايوبسي ممكن بعد كده تقول انا ما كانش عندي حاجه وانتوا اديتوني زياده تريتمنت
بس هقول لحضرتك على حاجه، الايشو with the tissue from the bone هي دي the issue. ما اعرفش الباثولوجيست باك مي اب، انا بدافع عنه، انا بدافع عن الباثولوجيست. ايوه انا what I'm saying is والباثولوجيست هيقولوا لنا بس طب لو هي اليومينال بريست كانسر why don't we give her the benefit of the doubt ونديها الهرمونال and within 6 months we do the follow up. يعني قصدي لو انا from my opinion I will let the pathology مش هتدخل طبعا سيب retrograde او therapeutic test وبعدين ابقى اخد البايوبسي. I'm not against the biopsy but I'm against it up front.
If it is a solitary disease.
ما هي مشكلة على حسب ما أنا لو هو destructive lesion وعندي soft tissue component ما أنا باخد البيوبسي من soft tissue. لا أنا قصدي ما هي destructive وأنا باخد من السنتر اللي هي الحتة اللي هي فيها الميدس. لكن لو هي معظمها سكليروتيك واضطريت اعمل دي كالسيفيكيشن هو ده السيتويشن بقى الدكتور احمد بيقول عليه بيبقى فعلا صعب لان الدي كالسيفيكيشن بيعمل ديستراكشن للسيلز فما بقدرش بعد كده اعمل عليها اي حاجه.
طب انتوا رايكم
طب انا ممكن اسال سؤال بس في حوار البون ده ان انا اخد بايوبسي. انا المفروض البايوبسي البون انا عارفه ان هي بتبقى يعني او على قد معلوماتي يعني ان هي بتكون صعبه شويه. طب انا لو خدت بقى بايوبسي من البون وطلعت نيجاتيف وهي اصلا ميتاستاتيك هعمل ايه؟
صعبه في ار ستيننج صعبه في الديفايننج لما ما يكونش عندك تولز. لكن لو احنا في بهيه بنتكلم على مؤسسه عندهم فورمالين اب تو ديت وخدنا البيوبسي وادينا هو ده برضه سؤال جدلي بايوبسي سؤال جدلي actually بس you have a destructive lesion with PET-CT criteria and high FDG uptake and bony destructive lesion. It's there because let me ask you what is the favorable criteria of the patient receiving CD46 plus AI surviving till now after 8 years or 10 years from their treatment? The patient with oligometastatic started AI CD46 upfrontly without any previous chemotherapy. For the patient premenopausal patient receiving LHRH plus AI plus CD46 and patient with bone disease. The vessel disease, the benefit is there. But the most patients surviving 8 years from the time of initial of trials till now, about 9 years, are surviving with CD46 plus CI after defining of the oligometastatic disease. That's why, Dr. Muhammad, I want to have a rules. If you have a rule with your patients, عقد اتفاق من الأول, NTM1 disease, there is no chemotherapy for a new adjuvant, there is CD46 plus CI. There is a surgery if you are going for a surgery after long time of stabilization. It's very important from the first meeting with the patients. Don't postpone your brain after 6 months.
Now they are talking about modifying and not giving FDG. I was attending 3 weeks ago, they were doing an estrogen receptor targetable PET-CT. Sorry? لا لأن الإيفيدنس عليه it's not that high still because also in triple negative it has zero role and it depends on the estrogen receptor concentration. Yes. Yes. Maybe in the future طبعا ومش هنجيبه بهية برضه عشان ما نقولش حاجة بس عشان لا الايستروجين.
I have just a comment. I think this is an area of unmet need, and the clinical trials is the only way to answer these questions. We will still have different opinions, different patient scenarios, 1 lesion, 2 lesions, to take a biopsy, difficult or not. But at the end of the day, I think we are in the era of oligometastatic disease now in different disease areas. In breast cancer, till now, this question is not clearly answered. I think we have to establish guidelines or clinical trials to have clear guidelines. As Professor Sabri said, we have to have rules, and we can get this from clinical trials. This is my comment. Thank you.
انا ممكن اقول حاجه بس. هو فعلا اخر 2 سلايدز انا كتبتهم هو انا كاتباهم ريجاردنج ده ان احنا ما عندناش بروسبكتيف ترايلز في الموضوع تتكلم اصلا عن فكره الاوليجوميتاستاتيك حتى بموليكولر بيولوجي واحد. يعني حتى الستاديز اللي معموله مش لازم بتكون واخده بون اونلي ديزيز، يعني ساعات بتكون واخده بون وليفر، ما بتبقاش واخده كله اللومينال، بيبقى ساعات بيبقى منشند فيها تريبل نيجاتيف، منشند فيها تريبل بوزيتيف. فكل الستاديز كده. وانا براجع المفروض شفت في ستادي كانت معموله على اليومينال بليفر ماتس، بسنجل ليفر ماتس، دي ادوها فعلا الاي اي ال اتش ار اتش وسي دي كي 4، وكاتبين ان العيانه المفروض كونتينيود السي دي كي 4 3 سنين ووقفت ومنتند على هرمونال، وان العيانه ستيل لسه فولوينج يعني. في حاجه تانية لقيتها كان مكتوب ان في واحد يعني ان هم عايزين نكونسيدر الاوليجوميتاستاتيك كنيو ادجفنت، وعملوا زي نيو ادجفنت، اديله نيو ادجفنت كيموثيرابي then surgery then adjuvant treatment like metastatic مادام single agents. دي كانت ستادي تانية انا لقيتها مكتوبه regarding الموضوع. لكن اكتر ستاديز موجوده فعلا هي اللي بتأوجمنت فكره الاي اي ال اتش ار اتش سي دي كي 46 وكونتينيويشن للسي دي كي 46 بعد. بس احنا دلوقتي في مصر ما عندناش، يعني انا ما عنديش فيرست لاين سي دي كي 4، فاعمل ايه؟
about حوالي ويب كاست حوالي 4-5 محاضرات على الاوليجوموستاتيك في الاسمو 2021 available data for free for any non-ESMO member. You can revise all the data. All data from trials are retrospectively from many trials, not prospective, because you have no large number for patients for prospective. And all the guidelines recommend to tailor your local treatment after optimal systemic control without omission of the optimal systemic control. This is the medicine. Don't ignore the medicine and think about the case about eradicate the tumor. It's not eradication. It's not a leukemia. It's a breast cancer. Even the patient with non-metastatic receiving adjuvant with 10 years extended treatment. So eradicate the tumor is not a language for a breast cancer. Maybe language for a lymphomas or leukemias or even non-cancer or RCC. But with breast cancer, you should go live with the patients with good systemic control and maintaining response, not achieving response right now.
Okay, by the end of the session, we thanks all the teams for delivering this
Thank
very
you.
nice presentations. Thanks for you, thanks for the panel, and of course, thanks for all the attendees, and to have seen you, inshallah, next time.